Hello everyone, in this video on obstetrics, so today we'll be talking about breech presentation. The breech presentation, in breech presentation the lie is longitudinal, the podalic pole presents at the pelvic rim, and it is the most common malpresentation. The incidence is about 20% at 28th week, which drops down to 16% at 32 to 34th week, and it again which again drops down to 3 to 4% at the term. So that's why 3 out of 4 spontaneous correction into vortex presentation occurs by 34 week. So the incidence is expected to be low in hospitals where high parity birth are less and routine external cephalic version is done in antenatal period. And there are two varieties of breech presentation. One is complete and another one is incomplete. The complete breech is also known as flexed breech. This is flexed breech. The normal attitude of full flexion is maintained. The thighs are flexed at hip and legs are flexed at knees, and the presenting part contains of two buttocks and the one external genitalia and 2 feet, and it is commonly present in multipara women. And incomplete breech means that due to varying degree of extension of thigh or leg at podalic presentation, this is incomplete breech occurs. And there are 3 varieties are possible. One is breech with extended leg, frank breech, one is footling presentation, and one is knee presentation. This is one of the type of the incomplete breech. This is breech with extended leg, that is also known as frank breech. In this condition, thighs are flexed on trunk and legs are extended at knee joint. The presenting part consists of 2 buttock and 1 external genitalia. But in complete, there was in addition to this, presenting part was 2 feet. But here is only buttock and external genitalia is presenting part in this frank breech, and it is commonly present in primary gravida, about 70%, and in the increased prevalence in the primary gravida is due to tight abdominal wall, good uterine tone, and early engagement of breech. Complete breech was present in multipara. And this is the picture of footling presentation. Both of the thighs and legs are partially extended, bringing the legs to present at brim. And this more commonly is seen in preterm deliveries. And in attempt to find out the dangers inherent to breech, the breech presentation is clinically classified as uncomplicated and complicated type. In the uncomplicated type, it is defined as one where there is no other associated obstetric complication apart from the breech, and prematurity being excluded. Except prematurity and breech, there is no other associated obstetric complication in uncomplicated breech presentation. And in complicated, when the presentation is associated with conditions which adversely influence the prognosis, such as prematurity, twins, contracted pelvis, placenta previa, it is called as complicated breech. In uncomplicated, only the breech presentation is only breech is the complicated one. But here in complicated, the prematurity, twins, contracted pelvis, placenta previa, these all obstetric conditions are associated which adversely influence the prognosis, and it is also called as complicated breech. The extended legs, extended arms, cord prolapse, or difficulty encountered during breech delivery should not be called complicated breech, but they are what are called complicated or abnormal breech delivery. So what we just said now is that complicated breech and complicated or abnormal breech delivery are different thing. Now talking about etiology of breech presentation, there is higher incidence of breech in earlier weeks of the pregnancy. Smaller size of the fetus and comparatively larger volume of amniotic fluid allow the fetus to undergo spontaneous version by kicking movement until by 36th week, when the patient becomes stabilized. Here the following are the known factors responsible for breech presentation, and in the significant number of cases the cause remains obscure. And the prematurity, it is the most common cause of breech presentation. Prematurity is the most common cause of breech presentation. The factors preventing spontaneous version, for example, breech with extended leg, twins, oligohydramnios, congenital malformation of uterus such as septate or bicornuate uterus, short cord, relative or absolute, intrauterine fetal death of the baby. These factors prevent spontaneous abortion, and there is another cause. And the unfavorable adaptation of breech, such as hydrocephalus, the big head can be well accommodated in the wide fundus. That's why the head lies in upward but breech in downward. And in placenta previa, contracted pelvis, cornual attachment of placenta, these all minimize the space for the space of the fundus where the smaller head can be placed comfortably. And undue mobility of fetus in, for example, in hydramnios, polyhydramnios, multipara with lax abdominal wall, due to undue mobility fetus, breech presentation can occur. And fetal abnormalities like trisomy 13, 18, 21, anencephaly, and myotonic dystrophy due to alteration of fetal muscular tone and mobility, these can cause breech presentation. And occasionally the breech presentation recurs in successive pregnancy. When it recurs in 3 or more consecutive pregnancy, it is called as habitual or recurrent breech. The possible causes are congenital malformation of uterus, septate or bicornate, and repeated cornual fundal attachment of the placenta. And in general, recurrence rate ranges from 8 to 10%. The diagnosis of breech presentation can be made by clinical and by sonographical method. The diagnostic feature of complete breech are the as follows. Here we can see we have to do per vaginal examination and per vaginal examination for the diagnosis of breech clinically. In per abdominal exam, in the lateral fundal grip, the head suggested by hardened globular mass, head is ballotable in the complete breech, whereas in frank breech, again we can find the head due to hardened globular mass. Irregular small part of the feet may be felt in the frank breech by the side of the head. And the head is non-ballotable due to splinting action of leg on trunk. And in lateral grip, the fetal back is to one side, irregular rim to other. Again, irregular part are less felt on side. In the pelvic grip, the breech suggested by soft, broad, irregular mass is seen. The breech is usually not engaged during pregnancy. The small, hard, and conical mass is felt. The breech is usually engaged in the frank breech. The fetal ultrasound usually located at a higher level around about the umbilicus. It is lower level in the midline due to early engagement of the breech. The per vaginal examination shows that during pregnancy and labor, soft irregular parts are felt through the fornix, and the palpation of ischial tuberosity, sacrum, and feet may be side of the buttock. And the hard part of cervix is often mistaken for the head. Palpation of ischial tuberosity, anal opening, and sacrum, and they are on one line. And the chance of cord prolapse is 5%, chance of cord prolapse is 0.5% in the frank breech. Next, we can do diagnosis by ultrasonography. It is most informative. We have to do USC to confirm the clinical diagnosis, especially in primary gravida and engaged frank breech or with the tense abdominal wall and irritable uterus. It can detect the fetal congenital abnormality and also congenital abnormality of the uterus. The type of breech, complete or incomplete, it measures biparatal diameter, gestational age, and estimated weight of the fetus. And it also localizes the placenta. The assessment of liquor volume, important for external cephalic version. Attitude of head, whether it is flexion or hyperextension, important for decision making at the time of delivery. And CT and MRI can be used to access the pelvic capacity in addition to above mentioned information. And the sacrum is the denominator of the breech, and there are 4 positions. In anterior position, sacrum is directed towards the iliopubic eminence, and the posterior position, sacrum is directed to sacroiliac joint. And there are 4 positions. First position, that is left sacroanterior, being the most common. Second position, right sacroanterior. Third position, the right sacroposterior, and fourth one is the left sacroposterior. Left sacroanterior is most common, RSA, RSP, LSP. Now we will talk about mechanism of labor in breech presentation. The sacroanterior position, we will talk the sacroanterior position is most common. In the mechanism of breech delivery, the principal movement occur at 3 places. One is buttock, shoulder, and head. The first two successive parts are to be born are bigger but they are more compressible, while the head, because of non-molding due to the rapid descent, presents difficulty. And each of the three component undergoes a cardinal movement as like normal delivery. And we talked about normal labor in previous video. Okay, now we'll talk about the mechanism of labor in breech presentation. First one, we'll see buttock, the delivery of buttock. The diameter of the engagement of buttock is one of the oblique diameter of the inlet. The engaging diameter is bitrochanteric, 10 centimeter, with sacrum directed towards the iliopubic eminence. And with the diameter, when the diameter passes through the pelvic rim, breech is engaged, and the descent of buttocks occurs until the anterior buttock touches the pelvic floor. And the internal rotation of anterior buttock occurs through the one eighth of the circle. We can see here rotation of the internal rotation of anterior buttock, one-eighth of the circle, placing it behind pubis, and further descent with lateral flexion of the trunk occurs until the anterior hip hinges to under the symphysis pubis, which is released first, followed by the posterior hip. And the delivery of trunk and limbs follow, and the restitution occurs so that the buttock occupy the original position as engagement in oblique position. Now talking about delivery of soldier, the biacromial diameter of 12 cm engages in the same oblique diameter as occupied by the buttock at the brim soon after delivery of breech. The descent occurs with the internal rotation of the soldier, bringing the soldier to lie in anterior posterior diameter. Simultaneously rotate one-eighth of the part, and delivery of posterior soldier is followed by anterior soldier, and the restitution and the external rotation occurs in the soldier too. Similarly, the finally head is also the delivered. Now talking about complication of the vaginal delivery, there are the daily complication can occur in maternal or fetal. Labor is usually not prolonged in maternal, but because of the increased frequency of operative delivery, including cesarean section, the morbidity is increased. The risk include trauma to the genital tract, operative vaginal delivery, cesarean section, sepsis, and anesthetic complication. As a consequence, the maternal morbidity is slightly less. The frank breech acts as an effective cervical dilator. The frank breech, although theoretically might cause delay in first stage, but rarely so because of its prevalence among multipara. And the fetal risk in trauma perinatal mortality is considerable in vaginal breech delivery. The corrected perinatal mortality ranges from 5 to 35 per thousand birth, and overall perinatal mortality in breech still remain 9 to 25% compared with 1 to 2% for non-breech delivery. And the perinatal death excluding congenital abnormality is 3 to 5 times higher than in the non-breech presentation. The factor which significantly influence the fetal risk are the skill of the obstetrician, weight of the baby, position of the leg, type of the pelvis, and the fetal mortality is least in the frank presentation and maximum in footling presentation. The gynecoid and anthropoid pelvis are favorable for after coming head, and the fetal risk in multipara is no less than that of primigravida, and this is because of increased chance of cord prolapse associated with flexed breech. The danger to the baby are as follows: intrapartum fetal death, especially with preterm babies, the injury to head, brain, and skull, the intracranial hemorrhage, compression followed by decompression during delivery of the unmolded after coming head result in tearing of the tentorium cerebella and hemorrhage in the subarachnoid space, and the risk occurs more in preterm babies, and minor hemorrhages and fracture of skull can occur. Nextly, the birth asphyxia, it is due to cord compression soon after the buttocks are delivered and also when the head enters into the pelvis. A period of more than 10 minutes will produce asphyxia of varying degree. The retraction of the placental site, a premature attempt at respiration, amniotic fluid, vaginal fluid while the head is still inside, delayed delivery of the head, and cord prolapse in frank breech, prolonged labor. These all cause birth asphyxia. And birth injuries, the following injuries are inflicted during the manipulative deliveries. It is 13 times more than vertex presentation. Various injuries like hematoma over the sternomastoid or over the thighs. Fracture, the most common site are femur, humerus, clavicle, hip joint, and odontoid process. And there may be dislocation of hip joint, mandible, or fifth and sixth cervical vertebra, and epiphyseal separation. And the visceral injuries like rupture of liver, kidney, suprarenal gland, hinge, lungs, arm and leg, and hemorrhage in the testicles. The nerve like medullary coning, spinal cord injury, stretching of the cervical and brachial plexus to cause either ARFs or complex palsy, and long-term neurological damage can occur. Some of the injury may prove fatal and contribute to the perinatal mortality. And long-term neurological morbidity of the surviving infant should not be underestimated. And the congenital malformation are double compared with the babies with cephalic presentation. The congenital dislocation of hip, hydrocephalus, and encephaly are more common. And there are several measures which can prevent the fetal hazards. The incidence of breech can be minimized by external cephalic version where possible. And if the version fails or it is contraindicated, delivery is done by elective cesarean section. But the vaginal breech delivery should be conducted by skilled obstetrician along with organized team consisting of skilled anesthetists and neonatologists. And the vaginal manipulative delivery should be done by skilled person with utmost gentleness, especially during delivery of head. Now we will talk about antenatal management. The antenatal management in the breech consists of identification of complicating factor related with breech presentation, external cephalic version if it is not contraindicated, and formulation of the line of management, and if the version fails or it is contraindicated. And the identification of complicating factor can be detected by clinical examination, supplementation by sonography, and sonography is particularly useful to detect congenital malformation in fetus and precise location of placental site and congenital anomalies of uterus. And next step is we have to do external cephalic version, and we will talk about external cephalic version in next video about this. And so this flowchart shows the scheme for management of breech presentation. For we have to do antenatal assessment, fetal well-being, weight, attitude, maternal health, obstetric and medical, maternal pelvis. We have to do clinical pelvimetry, and next we have to do external cephalic version to be done at around 36 week or after in the labor suit with tocolytic if needed, fetal monitoring, CTG before and after procedure. And if it is successful, delivery as a vortex. If it fails, then trial of vaginal breech delivery can be done. And in trial of vaginal breech delivery, if satisfactory labor progress, then assisted breech delivery can be done. If it CS in labor, CS cesarean section in labor, if breech not on perineum after 2 hours of full cervical dilatation. If there is arrest of progress, fetal distress or cord prolapse, we have to do cesarean section. And we have to if external cephalic version fails, then we can do elective cesarean section after more than or equal to 38 weeks, and with the informed consent. Average fetal weight is 2 to 3.5 kg. Frank or complete breech, flexed fetal hair, adequate pelvis, and availability of the experienced obstetrician and neonatologist, and rapid CD if possible when needed. And elective cesarean section, the estimated fetal weight if it is more than 3.5 or less than 1.5, hyperextended head, associated complication like obstetric or medical, pelvic inadequacy, absence of expertise for delivery, antenatal fetal compromise, patient request or fetal factor like footling presentation, fetal growth rate retardation, and more than one prior cesarean delivery. In all these cases, this is overall the management of the cesarean delivery. Management of breech presentation. Now, how can we do the management of vaginal breech delivery? In the first stage of labor, the management protocol is similar to that of mentioned in normal labor, as we have discussed in previous video. You can check out the video if you haven't watched it. The following are the important considerations like spontaneous onset of labor increases the chance of successful vaginal delivery. And the vaginal delivery examination indicated at the onset of labor for pelvic assessment soon after rupture of membrane to exclude cord prolapse. And intra-IV line is cited with Dringer solution. Oral intake is avoided. Blood is sent for grouping and cross-matching is done considering chance of CS. Adequate analgesia is given. Epidural is preferred, but it increases the CS rate. And the fetal status and progress of labor are monitored. And oxytocin infusion may be used for augmentation of labor, but it is not routine and may be used with epidural. The indication for cesarean section are the cases seen for the first time in labor with presence of complication, arrest in the process of labor, non-reassuring fetal heart rate pattern, fetal distress, and cord presentation or prolapse. These are indications for cesarean section. And the second stage of labor, there are three methods of vaginal breech delivery. One is spontaneous, one is assisted breech, and one is breech extraction, partial or total. The one spontaneous, the spontaneous expulsion of fetus occur with very little assistance, and this is not preferred. It occurs only in 10%. And assisted breech, the delivery of the fetus is by assistance from the beginning to the end, and this method should be employed in all cases. There should be assisted delivery in almost all cases. And breech extraction, partial or total, when part or the entire body of fetus is extracted by the obstetrician. It is rarely done nowadays, as it produces trauma to the fetus and mother. Its indication are delivery of the second twin after IPV, internal podalic version, and the cord prolapse or extended legs arrested at the cavity or outlet. We will talk about assisted breech delivery. This is done mostly nowadays, and this is here the assistance is or the delivery of fetus is from beginning to the end, and this should be employed. And the breech delivery should be conducted by skilled obstetrician. The following are kept ready beforehand, in addition to those required for conduction of normal labor, like anesthetist to administer anesthesia as and when required, assistant to push down the fundus during contraction, instrument and suture material for episiotomy, pair of obstetric forceps for aftercoming aid if required, and appliances for resuscitation of the baby if asphyxiated. And we need the neonatologist. The principle of the conduction of assisted breech delivery is the never to rush, never pull from below but push from above. Always keep the fetus with the back anterior, and have patience to allow maternal expulsive forces. And it is expected that good uterine contraction and maternal expulsive forces will maintain the flexion of the fetal head and result in decent and safe delivery. And never to rush and never to pull. Early aggressive and hasty pull affects breech delivery adversely by entrapment of the aftercoming fetal head through the incompletely dilated cervix. Traction from below result in deflection of the head, posing longer occipital frontal diameter at the pelvic inlet, and increased risk of nuchal displacement of arm. What are the talking about steps of assisted vaginal delivery? Firstly, the patient is brought into the table where the anterior buttock and fetal anus are visible. She is placed in the lithotomy position when the posterior buttock distends in the perineum. And to avoid outer cable compression, the woman is tilted laterally 15 degree using wedge under the blanket under the back. The antiseptic cleaning is done. Bladder is emptied with the in and out catheter, and the epidural pudendal block is done along with the perineal infiltration. The episiotomy should be made in all cases of primary gravida and selected multipara. And its advantages are to strengthen the birth canal, which especially facilitate the delivery of breech with. Episiotomy should be made in all cases of primary gravida and selected multipara. Its advantages are to strengthen the birth canal, which especially facilitate the delivery of breech with extended leg where lateral flexion is inadequate, and to facilitate intravaginal manipulation and for forceps delivery to minimize the compression of the aftercoming head. And the best time for episiotomy is when the perineum is distended and thinned by the breech as it is climbing the perineum, and the bitrochanteric diameter is under the symphysis pubis. And oxytocin may be used. Epidural anesthesia is helpful in case of maneuver, and patient is encouraged to bear down as the expulsive force from above ensures flexion of the fetal head and safe descent. And the no touch to fetus policy is adopted until the buttocks are delivered along with leg in the flexed head and trunk slip up in the umbilicus. Soon after the trunk up to the umbilicus is born, the following are to be done. The extended leg in the frank breech are to be decomposed by the pressure. Here you can see the extended leg in the frank breech are to be decomposed by the pressure on the knee popliteal fossa in manner of the abduction and flexion of the thigh. The umbilical cord is to be pulled down and to be mobilized to one side of the sacral way to minimize compression. There may be transient abnormality in the cord pulsation at this stage which has got no prognostic significance. An attempt of the hasty delivery for this reason alone should be avoided. And if the back remains posteriorly, rotate the trunk to the bring back anteriorly, sacroanterior, and the baby is wrapped with sterile towel to prevent slipping when held by the hands and to facilitate manipulation if required. And we have to do the delivery arm. Uh, the assistant is placed hand is pla- assistant is to place a hand over the fundus and keep a steady pressure during uterine contraction to prevent extension of arm. Soon the anterior scapula is visible and the position of the arm should be noted. When the arm are flexed, the vertebral border of scapula remains parallel to the vertebral column, and when extended, there is winging of scapula. And the arm are delivered as one after another only when one axilla is visible by simply hooking down each elbow with finger, and it is immaterial as to which arm is to be delivered first. The baby should be held by the feet over the baby uh, the baby should be held by the feet over the sterile towel while the arms are delivered. And for the delivery of after coming of the head, and this is most crucial stage of the delivery. The time between the delivery of the umbilicus to delivery of mouth should be preferably the 5 to 10 minutes. There are various methods of delivery for after coming head. Each one is quite safe and effective in the hand of the expert and conversant with the particular technique. The following are the common method employed. One is bone Marshall, forceps delivery, and malar flexion and shoulder traction. So talking about bone Marshall method. This is a picture showing bone Marshall method. The baby is allowed to hang by its own weight. The assistant is asked to give the suprapubic pressure with the flat of hand in downward and backward direction. The pressure is to be exerted more towards the sinciput. The aim is to promote the flexion of head so that the favorable diameter is presented to the pelvic cavity, and not more than 1 to 2 minutes are required to achieve the objective. When the nape of the neck is visible, the when the nape of the neck is visible under the pubic arch, baby is grasped by the ankle with finger in between two, maintaining the steady traction and forming wide arc circle. The trunk is swing in upward and forward direction, and meanwhile the left hand is to guard the perineum and slipping the perineum off successfully the face and row. When the mouth is cleared of the vulva, there should be no worry. The mucus of the mouth and pharynx is cleared by mucus sucker, and the trunk is depressed to deliver rest of the head. Next method is forceps delivery. The forceps can be used as routine. Head must be in the cavity, and its advantages are delivery can be controlled by giving pull directly on the head, and force is not transmitted through the neck. Flexion is better maintained, and the mucus can be sucked out from the mouth more effectively. Head should be brought as low down as possible by allowing the baby to hang by its own weight, aided by suprapubic pressure. And when the occiput lies against the back of the symphysis pubis, an assistant raises the leg of the baby as much to facilitate the introduction of blade from above. And too much elevation of trunk may cause extension of head. The forceps pull maintain an arc which allows the access of birth canal. So this is the delivery of after coming head by forceps. This is Piper forceps with long shank. This is especially designed forceps for the use of forceps delivery, and the head should be delivered slowly over 1 minute to reduce compression decompression forces as that may cause intracranial bleeding. And the malar flexion, next one is we have the malar flexion and shoulder traction method, that is also known as modified Mauricio Ismaili beat technique. This picture shows the malar flexion and shoulder traction method, that is by modified Mauricio Ismaili beat technique. The technique is named after three great obstetricians who described the use of grip independently. The baby is placed on supinated left forearm, that is preferred, and with the limbs hanging out on the side. And the middle and the index finger of left hands are placed over the malar bone on either side, modification of the original method where the index finger was introduced inside the mouth. We have to do the two middle and index finger of the left hand are placed over the malar bone on either side, and this maintains the flexion of the head. And the ring and the little finger are pronated. Right hand are placed on the child's shoulder, and the index finger is placed on left shoulder. I will repeat it again. The ring and little fingers of the pronated right hand are placed on the child's right shoulder, and the index finger is placed on the left shoulder, and the middle finger is placed on the suboccipital region, and the traction is now given downward and backward direction till the nape of the neck is visible under the pubic arc. and the assistant gives a suprapubic pressure during the period to maintain the flexion. Thereafter, the fetus is carried out in the upward and back forward direction towards the mother abdomen, releasing the force flow, and lastly, the trunk is depressed to release the occiput and vertex. And the resuscitation of baby maybe should be done if the baby is asphyxiated and need to be resuscitated. The third stage is usually uneventful. The placenta is usually expelled out soon after delivery of the head. If the prophylactic and oxytocin is to be given, it should be administered intramuscular following delivery of head. And the preterm breech external cephalic version with preterm breech presentation is not recommended. And the cesarean section is commonly done when fetal weight is less than 1500 gram. However, it is not yet known whether the better parental perinatal outcome is due to the CS or greater use of antenatal steroid or better in neonatal care. And spontaneous delivery, often the cervix is incompletely dilated, and this may allow the delivery of a smaller body, but the relatively large diameter after coming head may be contract, and the prompt delivery is mandatory to avoid the risk of severe hypoxia and fetal death. And further closure of the cervix and the gentle downward traction on the shoulder combined with fundal pressure applied by an assistant may ensure delivery. And the use of inhalation anesthesia may be helpful if it fails. And Durson's incision are made to release the entrapped head and delivery. And the incision are made at 6 o'clock and if needed 2 o'clock and 10 o'clock position. Now we will talk about management of complicated breech delivery. And when a woman present in advanced labor, it may be difficult to decide what should be the ideal mode of delivery. However, if the breech is not visible at perineum, even after 2 hours of full cervical dilatation, it may be possible to deliver the baby by CS. And simulated teaching using mannequin and modal pelvis with experienced trainer can improve the skill and performance of such maneuver. In the delay in the descent of the breech may be arrested at the outlet, in the cavity and at the brim. If it is arrested at the outlet, the causes may be big size of baby with extended leg, that is common, and weak uterine contraction, rigid perineum and outlet contraction. And if that is managed, it is managed by cesarean section. And in the absence of outlet contraction and fetopelvic disproportion, that liberal episiotomy and fundal pressure with or without groin traction, either single groin or both the groin usually becomes effective. So that can be done. If there is arrested of the breech or at or above the level of scale is fine, the causes may be pelvic contraction, big baby, weak uterine contraction. The best treatment is by cesarean section. By the time cervix is fully dilated, breech should be descend down to the perineum, and this is called as trial of breech. And we have the frank breech extraction, that is also known as pinard maneuver. Here it is done by intrauterine manipulation for breech decomposition to convert a frank breech into the footling breech, and this is possible when the membranes have ruptured recently. And in pinard maneuver, the middle and the index finger are carried up to the popliteal fossa, and it is then pressed and abducted so that the fetal leg is visible. The fetal foot is grasped at the ankle, and the delivery can be accomplished. Sometimes there can be extended arm. One or both arm may be fully stretched along with the side of head or lie behind the neck. Nuchal displacement. The cause is usually due to faulty technique in the delivery, using unnecessary traction, forgetting the principle of never pull but push from above. And the arrest occurs with the delivery of the trunk up to the costal margin. And diagnosis is made by noting the winging of scapula and absence of flexed limb in front of chest. And the management calls for urgent delivery of the arm, first by the posterior and then anterior one. The delivery of arm may be accomplished by adopting any one of the following method, like classical or lobset maneuver. In the classical, it works with a similar principle as lobset maneuver, and in addition, it needs intrauterine manipulation while the patient is under general anesthesia. Here the posterior arm is delivered, followed by anterior arm. Left hand is introduced along with the curve of sacrum while the baby is pulled slightly upward. With firm pressure over the humerus, the posterior arm is pushed off the baby's face, and the extended anterior arm is delivered from the anterior aspect by introducing the right hand in the same manner, while the baby's trunk is depressed toward the perineum. Now we have the lobset maneuver. The lobset maneuver is widely practiced in preference to the classical method of bringing down the arm. The following are its advantages, like wider applicability. It can be applied even when the classical method becomes difficult. Intrauterine manipulation is nil, and single manipulation is effective in all types of displacement of the arm, and general anesthesia is usually not needed. Its procedure are: the baby wrapped in the warm dry towel is grasped using both hand by femoropelvic grip, keeping the thumbs parallel to the vertebral column. The maneuver should start only when the inferior angle of the anterior scapula is visible underneath the pubic arc, and the baby is lifted slightly to cause a lateral flexion. The trunk is rotated through 180 degree, keeping the back anterior and maintaining the downward traction, and this will bring the posterior arm to emerge under the pubic arc, which is then hooked out. And in step 2, the trunk is rotated in the reverse direction, keeping the back anterior to deliver the arrest while anterior shoulder under the symphysis pubis. And the nuchal displacement of the arm is where the arm is flexed at elbow and the extended at shoulder and lies behind the fetal head. After grasping the baby at pelvic girdle with thumbs along the sacrum, trunk is rotated 180 towards the fingertip of the trapped arm, and this may draw the elbow forward and render it is amenable to lobster maneuver. So this is the process of lobster maneuver. If the arrest of aftercoming head is there, then the cause might be deflex head and contracted pelvis and hydrocephalus, and there are various management protocol. The best management is the delivery by forceps, which is effective, and that is what we have to do. The principle is not so important. So that was all about breech presentation. So in next video we'll come up with a new topic in obstetric. Till then, thank you, and thank you for the patience up to the as we have come up with the last video on obstetric. So thank you and have a good day.